Well, hello again. Hopefully everybody has had an opportunity to grab lunch. If not, certainly feel free to bring it up to the tables up front. So that we respect your time, we'd like to keep going and stay on time with our agenda today. Our next presenter is Steve Waldren. He is a senior strategist for the Center of Health Information Technology at the American Academy of Family Physicians, which headquarters here in Leawood, if I remember correctly. Steve is a nationally recognized expert in health information technology. He is a senior strategist at the American Academy of Family Physicians Center for Health Information Technology. Dr. Waldren is also a residency-trained family physician. So we're going to hear from a clinician today and his topic and how it applies to the workforce. So Steve, thank you.
So typically I don't talk a lot about the workforce. Usually it's more about talking to physicians about adopting the technology. But I got the chance to sit in on a subcommittee of a policy committee that was looking at workforce, and then my opportunity to work on the advisory board here at Johnson County. Deb asked me to come and talk about this. So what I'm going to try to do is trying to organize things. So I think what a lot was said today that I'm going to kind of repeat a little bit, but what I want to do is try to put it a little bit in a different spin, and my spin being more from a clinical perspective and more of an ambulatory perspective. So first off, though, I think what's important, and I think it was alluded to, but I don't know if it was actually said, that we have this workforce issue in healthcare in general. This is a map from HRSA, which is a federal agency that looks at those places that are underserved, and anything that's colored here is underserved medically. And then if you look at primary care, which is where I focus a lot of my efforts in the advocacy space, it's even a little bit worse. So you have this background healthcare shortage issue, and then we're going to talk about healthcare IT workforce shortage. So you're going to see a lot of activity around this workforce shortage issue in healthcare in general. And all these numbers are before the ACA, healthcare reform, meaningful use. So those things I think are going to exacerbate that, including the Medicaid expansion part of the ACA bill. So there's a lot of activity going on nationally looking at workforce. If you just look at the provisions in the ACA, you're going to see where they were talking about looking at increasing the innovation, looking at increasing the workforce supply, also looking at education and training. Another whole thing about education and training, and this is healthcare specific, it's not healthcare IT specific. And then also looking at particular areas like primary care. Before this bill, though, was the Healthcare High-Tech Act, which is part of the Investment Act or the stimulus package, and we'll go a little bit more into detail what's going on specifically about HIT. So I just wanted to set the stage that the healthcare workforce issue is larger than just the IT issues. The other thing, and it looks like it's not going to present extremely well here. My slides are a little bit bigger. There was some discussion earlier when Julie was talking about the changes in healthcare. This is the way that I kind of tried to picture it. If you think of the healthcare as this world, the sun today is volume-based payment. So that's where the whole healthcare system orbits around. And what the focus there is, it's about documentation. So it's making sure that my review of systems, I have 9 systems checked off in the documentation, or I have 13 if I want to do a level 4 visit. Make sure that there's 3 or 4 items in my history of present illness. That's what the focus is on. The other focus is on maximizing utilization. So how many procedures can I do? How many individuals can I see in my practice? So there was discussion earlier when Julie was talking about texting, and there was discussion about somebody mentioned that, oh, the providers don't want to do it. Well, it's because there's usually not a reimbursement stream for that, and they're not able to see patients, they're not able to do procedures, so it's extra time, it's administrative time. But where we're headed is there's a new sun, and that's a value-based payment. And you may hear things like patient-centered medical home or accountable care organization. All that is dealing around making sure that the quality, you're rewarded the higher quality you get, the better reimbursement you get. The more efficient you can be with healthcare dollars, the more revenue that you'll see. And that's where the future is at. And that deals with issues around making sure I know what my costs are, making sure I'm looking at a population. So now I'm concerned about all my diabetics, not the diabetic that's sitting in front of me in the exam room. And data is the currency. If I don't have good data, high quality data, I don't have access to that data, there's no way that I can manage value, and I'm just going to be at risk. I'm not going to be able to game the system. Documentation, you can game the system. We see that all the time. I get docs that come to me complaining about their cardiologist. He just sent me a 6-page note, and all he said was status post-MI, doing well, no change in therapy. And I had to wait through 6 pages to try to figure that out. Because it's really about documenting to make sure that that was a level 4 visit, not how do I document that, what is the care that's needed for that particular patient. So I think that'll be a big change when you think about, from an IT perspective, what are the skill set, what are the competencies are needed? These are different. It'd be nice if we could just move from one sun to the next, but I think we're going to have a binary system for quite some time. And there's really value in some of this volume-based stuff too, if it's something that you really want to drive utilization. So immunization. So there will be a blended payment model as we go forward, which also I think impacts the workforce because you're going to have a lot more complexity on the administrative side than we currently do today. This slide, I think, is interesting because I think when a lot of people talk about, and I actually added this in after there was some discussion this morning. This is a slide from 1961, and it was updated in probably about 2006, 2007, and this is called the Ecology of Medical Care. So what you'll see in the big box that you can't see the end of is if you look at 1,000 people, just a random selection of 1,000 people in the population, and you start to look at, well, 800 of them, we're going to end up having some reported symptom. From those, maybe only 327 decide that they want to seek some type of care. And you start to drill down, and you start to look at, 8 are hospitalized out of that 1,000. If you look at where are the cost, where are the resources, where's the money being spent, it's the exact opposite of this. The big box is all the way down in the tertiary care, the large medical centers or those people that are in the ICU. And Andy Grove, who was a chairman and chief executive at Intel, talked about this shift left that he wanted to push. So he wanted to be able to push things off to the left. So as you think about things that we used to do in the ICU, now they're on the floor. My wife had a huge surgery back in December. Cracked her chest open, repaired a bunch of stuff. She was in the ICU 2 days. She was in the hospital for 6 days. If you think back 10 years ago when her mother had the same type of thing, she was in the ICU for about a week and a half. She was in the hospital for a little over 2 weeks. That left shift is already happening. But if we can continue to drive that farther, then we're going to really be able to impact the cost curve more so than just changing things or tweaking things a little bit. So as you think about an IT workforce, yeah, I think a lot of people are going to go into the hospital space now, but as that starts to happen, more of the workforce is going to need to go moving out and farther out into the left. So that's how I see some of the big changes or challenges in healthcare as it relates to kind of the technology workforce that we need. There was a recent study that was, or actually survey, not really a study, that was done by PwC, and they asked CEOs, what are the top issues that you needed to deal with? And 2 of them had to do with talent, making sure that they actually have the right talent. They're going to really change the way that they look at acquiring talent because of the shortage issues. And the other 2 things dealt with technology. So, as everybody knows in this room, that the workforce challenge issues in IT are going to be enormous moving forward. You also then ask the same type of questions from the provider. So these are the people in the ambulatory space. A little over 2/3 of them say, that there's an IT shortage. I need to figure out how to improve the staffing. A little over half are saying that it's actually impacting my bottom line because I can't achieve meaningful use. And as we think about meaningful use being pretty simple compared to actually implementing things to really get to value-based payment, that's going to be an even bigger challenge as we continue to move forward. And then 75%, 3 out of 4, say that they're going to be hiring. So even the ambulatory space now is figuring out how do I pull in talent into my into my practice. I thought this was kind of interesting. So this is from that same survey, and they were trying to figure out what were the priorities of people that you were looking for. So I wasn't too surprised that you see this big chunk of people in the clinical informatics and this big chunk of people in systems and data integration. Goes back to that notion of thinking about meaningful use and accountable care. Now I all of a sudden have all this data. I have the implementation of the EMR. Now I actually have to use it to really drive care because now my costs are going to be associated with that. And you see a very small percentage, about 10%, that was saying really I think focused in on getting the technology in place. In our membership of family medicine, a little over 70% of our active members have an EMR in place today. Those remaining 30% are not going to have as much issues with the technology and support because they're going to go with cloud-based solutions. So I think as you look at this donut graph moving forward, that 10% is going to continue to shrink. If you think about it from a provider perspective and from a hospital perspective, more and more stuff is going to go to the cloud. You're going to have the end devices that you're going to have to manage, the issue we talked about earlier this morning about the mobile device. But managing the servers and doing those type of things are going to be less important, in my opinion, moving forward. What I was really surprised about was that only 9% had issues around looking at data statistics and analysis. We heard from this morning about big data and how the analytics are important. And then I thought, oh yeah, I know why this is only 9%. It's because this is the provider space. So this is the hospitals and the ambulatory practice. It's not the EMR companies. Currently today, this is really a black box, I think, for a lot of the providers. So the EMR has those data analytics, has those data visualizations. I, as a doc, wouldn't be able to pull my data out and do any type of analytics and take a look at and see how I'm doing. I'm really dependent upon the EMR company to be able to do that. So as we start to get some more interoperability, and I think we start to see the business things aligning to really drive that, I mean, Commonwealth, which was just announced at HIMSS 2013, is the first kind of big salvo saying, okay, EMR companies say, we're going to forego the issues that we have with allowing customers to substitute, right? Because they're not going to want the interoperability from that standpoint because I can jump ship from one EMR to the next. But they're starting to see where they're not going to be able to make sales and they're not able to continue to move forward if they don't have the interoperability. So again, I think we'll see that growth in that data statistics and analytics and more of that, again, kind of that left shift, moving out of the EMR proprietary vendor and Nginx type of organizations and moving that out to the hospitals and then finally out to the ambulatory space. So as you think about your workforce over the next 10 to 15 years, having that type of capability, I think, is important. And I'm not sure what to make of the fact that 15% don't know what their priority is. And maybe that's just the laggers. I think we have those in the space, too, that they say, I'll retire, or you'll pull the manila folder out of my dead cold hands, but still don't quite understand that. So the last thing I want to do kind of in the setting this stage a little bit is talk about some of the statistics. I looked everywhere for statistics. And again, this is not my forte to have these numbers. What I would say when you're looking at this slide, look at the magnitude and look at the trends. Don't look at the individual numbers. I think the precision that we have relative to these numbers are not very good. But the U.S. Bureau of Labor said that they believe that they're going to need another 51,000 health IT professionals just to deal with the demand of meaningful use. And again, remember, I think meaningful use is about that much effort compared to about that much effort when we actually get to real value-based payment. And if you look at the numbers in 2008, they were estimated to be 172,500 of those. So that's a big percentage increase just for dealing with a meaningful use. And I've seen numbers anywhere between 28 to 36% increase from 2010 to 2018 in regards to the number of IT professionals that are needed. The next one is there's this category called medical records and health information technicians, if you go into the U.S. Bureau of Labor. And they give you so they have these statistics for any type of occupation. Well, this is the only one that I could find that had to do anything with health IT workforce. But if you look at the median pay in 2010, it's about $32,000. I would suspect it's more than that today. They estimated that there were 179,000 of those jobs. So again, see, we're getting some conflicting information. And they expected, again, that the change from 2010 to 2020 was about 37,000 in that. So again, another increase. Then if you look at the training programs, so Deb talked about this particular training program. Well, if you go back and look at the data, the only data I could find was from 2006. So this is prior to anybody talking about meaningful use at all. It was even before the first, I think, writing of the HITECH Act was put together, that there were only 718 health IT training programs, and there were a little over 8,000 trainees that were given a degree. It's interesting that 90% were made up of females. In my class in 2004, I think it was the exact opposite. So I thought that was kind of interesting. You nurse informaticists, I bet, is why that's so high. You guys have been around a lot longer than 2006. You've really been leading the effort. Us physicians kind of come in behind you. Don't tell my other physicians I said that. But you look at the actual degree levels, though, that over half were just a certificate, and you go up the level of more and more training that only 0.5 were of a doctorate level. All right, so that's 2006. You had a little over 8,000. The training programs like this one in the consortium have already trained over 12,000 professionals since 2010. So again, and we're still seeing the shortage issue, so we're still seeing that growth in the training programs. And I think we've seen increases in the bachelor's and the master's degree programs as much, but not to the degree we've seen in the certificate programs. So these are, I think, what I would consider my takeaways when I think about the health IT workforce on a national perspective. The IT workforce shortage issue is part of a larger workforce issue. So you're going to see a lot of activity on workforce, and that may be good or may be bad as it relates to IT. But you're going to be competing for training dollars. As we know, we have these budget issues moving forward at the national and state level. You're going to be competing against, do we have enough doctors? Do we have enough nurses? Do we have enough respiratory therapists? The other is this notion of incumbent workers. So there's been a lot of discussion of increasing the number of training programs that are out there. There's been less discussion of, well, what about the workforce out there that's revolving around the sun of volume-based payment? And they don't have the skill sets that are needed for the value-based issues that we have moving forward. So there's been a lot of discussion of how do you train those incumbent workers, and what's the competency difference between what they have today and what they need moving forward. And then the final thing I would say is that in the near future, I think the demand is going to be more in the informatics and what I'm calling the applied systems. So this is the people that understand the workflow, the human factors, dealing with the analytics, saying, well, what's this data mean? What can I interpret from the data? I think those are going to be the big skills, the big boom in regards to both the number and where the high-paying jobs are going to be at in the health IT in the next decade or so. I hate talking about the timing because it seems like every time I hear, like for interoperability in my world, oh, in the next 5 years, we're going to do X. Well, I've been around for a couple 5 years, and we still aren't much closer in that. So we may not make it there in 10 years, but I think that's probably a time frame that I would say I'd feel comfortable make a small bet on. Probably not a big bet. Does that make sense? Does that kind of fit with the way that people in the audience are kind of seeing the issues as we move forward? Kind of sound like when I heard the panel and Julie talk earlier that those were kind of the same things. So the last things I wanted to chat about is what is kind of specifically going on for HIT workforce. So the Office of the National Coordinator has this workforce development program. There's four big components to it. The first is the university-based training. So they've ramped up the training programs. I did a university-based training program at the University of Missouri. And when I did it, there were only a handful of medical informatics sites. Now there are several, and there's several that are online. So you can actually go to Stanford. Oregon Health Sciences also has an online program, so you can do it virtually. MIT has some courses that are online. I don't know if you can actually get a certificate or anything from them, but you can take some of those courses. So they tried to beef up that residency training, or not residency training, but university training. The next is the College Community Consortium, and like I said, this is what's going on here at Johnson County Community College. They've already trained nationally over 12,000 individuals. So they've really tried to get that large workforce ready to get into the marketplace. And again, this was focused on those people that have some technical expertise and giving them the healthcare expertise, or having the healthcare expertise and giving them the technical expertise. And that's why it can be done in 6 months instead of a 1 or 2 year program. The other was that there really wasn't a whole lot of curriculum already available for folks to just pull off a shelf and say, oh, here's the level of competencies, here's the skill set, here's the knowledge that you need, here are the information sources that you need to teach that. So they created another consortium looking at developing that education materials. So that's available out there if people want to take a look at and incorporate into their training programs. And the main purpose was to help support the community college, but it's available for anybody that has any type of that training. And the final thing was the competency examination. So, you know, you could have a certificate, but we're actually being attested to say, yep, they have those skills. So they also created an examination program so you can get certified in things. There's a lot of different certifications in health IT. I think that's anything significantly new, but that was added to the program. So these are some of the things that are just specific to health IT. And we're talking about quite a bit of money. I don't remember exactly how many billions went into the training, but it is a significant effort just for that. The last thing I wanted to chat a little bit about was competency. So this doesn't really fit into the whole flow of the lecture, so please bear with me. But I thought it was important as we start to think about, well, we're training all these people. Well, what are we training them in? What are their competencies? Who are we training? This is a model that was used by a lot of folks looking at what are the competencies needed for health IT. So you have this tiered approach where you have some basic competencies, interpersonal skills, professionalism, and then as you get up to the top in the yellow, then it actually gets to something specific to our industry. And I think that's helpful as you start to think about making sure that you have education and training, or you have certification criteria for these different aspects. But one thing that I thought was important as I was on this workforce task force looking at work group task force looking at workforce, that they were talking about, oh, we need to train these people. Well, who are these people? It really depends upon what their role is and what their setting is. And then you can start to talk about what their competencies are. So this is something that we used as kind of a mental model. So the blue one on the X or the Y-axis, you have what is their role. So are they dealing mostly from an administrative standpoint? Are they a practice manager inside of a practice, or are they part of a hospital administration program? The next is, are they part of the clinical team? Are they individual caregivers? So thinking about the lay public, do we need to train them in certain aspects if they're going to be using their personal health records, all the way up to the actual clinicians? And then you think about the setting. So is this in an inpatient setting, or is this looking at an ambulatory, or is this looking at somebody that's going to be trained to work in public health? Those are different. And then finally you look at the Z-axis in the yellow saying, well, there's different domains. So you have informatics, like terminologies, ontologies, and then you have research methodology, you have medicine. So each one of these roles combined with a particular setting is going to have a different set of competencies in each of these. So somebody may need to know that there's such thing as research, things like consents needed, that there's randomization, but they don't need to know how to do the statistics and those type of things. So what you're able to do with this model is start to say, then these yellow boxes say, here are the set of competencies that are needed for a technical person working an inpatient as it relates to informatics. So you can start to get a handle on what you actually needed to train these folks. So I thought this was interesting because I think some people just think about the HIT workforce as this one big block of group, and maybe it's the technical folks and the clinical folks, but it's really significantly different. If you're working in a hospital versus ambulatory, or you're working in a public health entity, your skill sets are going to be drastically different in what you're going to need. So I talked about that workforce task force that I was on. It reports up through the HIT Policy Committee to ONC. These are the draft recommendations. These have not been finalized, haven't been pushed up. And I think what's important here is not as much what the recommendations are, but what are they trying to focus on? What issues do they think need to be addressed? So as you look at these, I already talked about the incumbent workers. So they're wanting to look at what's the retraining that's needed for the current workforce that's out there as you think about team-based care, population, those things that are needed for value-based payment. The other is this notion of widely disseminated. So we had a group of quote-unquote experts in workforce in this work group, plus me, and people didn't know what was going on. So somebody'd say, oh, well, there was this study on this, or this group doing this type of work, and everybody else say, well, I didn't know that. So they said that we really need to make sure that it's widely disseminated. And like I mentioned, the team-based care and population health is a critical change if you think about value-based payment. Typically, we're not trained to do that. We're trained to take care of a patient by ourselves and that individual patient that we're seeing in front of us. And then the other was to really look at effectiveness of the workforce initiatives already. So we spent money, we've got these things spun up. Are they actually getting the outcomes that we really want? The other couple of things that I think were interesting is, one, that they want to be able to raise awareness of the training programs that are out there and the resources that are available. This one here, the official recognition of workforce jobs and occupations. So on one of my first slides, when I said there's that one category of occupation that deals with health IT in the U.S. Bureau of Labor, this is a group saying we need to have significantly larger number of those so that we can start to talk about what are those statistics around those, what are the median, what number of jobs, what do we need. And then the final was they just wanted to be able to study the impact of HIT changes on the workforce. So when you think about not only the HIT workforce, but the healthcare workforce, and how is that going to change as we apply technology. So you think about telemedicine was talked about earlier. That changes the number of specialists that you may need in certain areas. So those are just some of the recommendations that the group was going through. So what I thought I would do is leave an ample amount of time for questions. I always get a little bit concerned, but it looked like you guys had a lot of questions earlier. So I'm happy to answer any questions you have relative to the workforce of the IT.
Okay. All right, Steve, thank you for your presentation. Any questions from the audience at this time? Oh, we have one in the back. How come they're never right next to me? Oh, no. I got you. Here you go.
Hey, good afternoon. My name is Suraj, and I'm a consultant with Dentalect. It's an EMR. One of the issues that we are facing is going through meaningful use. Okay. One of the issues we are facing is going through meaningful use testing and certification. Do you see that as a lack of skill, or is the process just that complicated? I mean, is that something that colleges are not training students in? Is that why there's a shortage in that field, or?
Yes. I think the answer is probably yes to both of those. I think the whole certification issue is something new. So certification started with just one entity. and it had nothing to do with the meaningful use. And then there was issue that was the vendor community controlling that one entity, and there's a lot of other things. So ONC decided that it needed to be opened up. So there's now multiple certification entities that are out there, and each of them can have a slightly different process. So I think there's the complexity dealing with, does Drummond have a different thing than CCHIT relative to do that? I think the other thing, too, on the technical standards, a lot of those standards are new, that we didn't have all the standards that we needed. So just in the last couple of years, we've seen the development of the standards that are required for that. You think about the direct protocol stack that's needed for directed exchange, that's just about a year old. You look at the continuity of care document, that's just a couple of years old relative to having the specifications for that templating. So I think there's a lot of newness there that it's hard to kind of do that. I think it would be interesting to see if the training programs could partner with, like Drummond and others, to be able to help some vendors go through that so they could learn about the process. But I think it's more the fact that there's just a lot of complexity there and it's new, more so than not necessarily being trained to go through that certification process.
Other questions on that side?
Hi, my name is Deborah, and I currently volunteer in a hospital in HIM, and I have a background in office information systems. If I was to pursue the high-tech program or get certified in medical coding, would that be an avenue to get into the health IT arena?
Yeah, and I mean, I'll give you my opinion. It's probably not the best opinion to ask for that. I mean, I think if you can find some of the folks that were on the last panel that are, employers, to be able to tell you what that is. What I've seen in the last couple of years is that it's moving where before, when I first got into this, that it was more about what you did, and could you talk about how the skill set that you needed. It wasn't important that you had a degree relative to HIT. If you had a clinical degree and you could talk about data, databases, terminologies, ICD-9, CPT, then that was sufficient. I think where we're getting today is that you need to have either a nice set of experience that you can go back to and say, here's what I did relative to clinical IT, or you're going to need to have that some type of certificate. I think the high-tech ones out there are one to look at. Again, if you're looking at getting in to not necessarily just the entry level, but the beginning level, but if you're looking at getting into director and those type of things, then that could be a start. But I think you're going to need to look at the potential of doing a little bit more training. Again, going back to looking at those different groups. If you're talking about a small hospital or you're talking about an ambulatory clinic that's in either a single large physician group or it's a small IPA, then I think they'll be looking for somebody that necessarily doesn't have to have a long pedigree of experience and degrees. They're looking at somebody that they can talk to and trust and can communicate with them, and they can kind of get ramped up. But if you're looking at a large academic medical center and those type of things, then you need to have that longer list, I think. I mean, other people, am I way off? Definitely jump in if you think I'm incorrect.
I agree with you. Myself, I'm the Chief Information Officer for a multi-specialty clinic. And up until 6-7 years ago, my entire background was in manufacturing. You need to be a student of the workflow. That's the biggest thing that you need. You need to be a quick study on what it takes to document, a patient's situation, their history. It doesn't make a lot of difference, really, honestly. I have one support specialist in our electronic health record system that prior to working for me, he was the audiovisual guy at an elementary school. And he's probably one of the foremost people in the country with the electronic medical record system that we use.
I mean, I think the thing I would add to that too is you can also find where the biggest shortage is. So, you know, with a coding background, I mean, knowing ICD-10, getting proficient in ICD-10, you know, people are going to need a lot of those folks. My organization is looking for a specialist in ICD-10, and we don't even bill. So you can also look at some of those niches, and that could get you into the marketplace and start to getting an experience and then pivot from there as well.
Hi, my name's Andrea, and I'm the manager of medical informatics at Shawnee Mission Medical Center down the street. And we are currently struggling, if you can imagine, with physician adoption and utilization of technology. And so we're always trying to find new ways to provide physician education. But do you think that you're going to see a shift in medical schools to starting that education process earlier and starting the technology education?
Yeah, absolutely. I hear it when we talk to our family medicine residents that, you know, they've used an EMR in medical school. They've used it in residency. They're not going to a practice that doesn't have an EMR. So I think it is going to be, you know, some adoption by attrition. So it's those old docs. We have a lot of old docs. I mean, old like 70s that are adopting an EMR. So you know, there's a little bit of stereotyping there, but I think you will see some of that attrition. And then also the discussion this morning about mobile and I mean, somebody that's in their late 20s finishing medical school and residency, you know, they've grown up with the internet and I mean, that's just, you don't have to teach them a lot of that stuff that we have to do for the other docs. On the adoption issue, some things that we try to do is if you can find some of the physicians that are trusted in the community that are open to do that and trying to help them become the champion to help you with that other adoption. You know, again, coming from the ambulatory space, a lot of times the people that are trying to do that adoption, all the physicians have a vested financial interest and there's control. So as being from a hospital, that if you have folks that are not salaried employed, I can see where that's going to be a bigger challenge. But I think finding those peers, because one of the things I think you can also get with physicians is if you can show them another physician that's their peer is doing better than they are, I don't care what it's in, it be soccer, they'll try to do better. So I think if you can try to lever that too and demonstrate that, you know, here are some docs that are really cutting edge, they're leading, they're delivering higher quality care, you'll see those other docs start to gravitate toward that too, I think, a lot. But it's going to be a challenge if they don't have a financial stake in the EMR.
Other questions? Okay. Steve, I have a question for you.
Sure.
One of the slides you were showing was the percentage of concern in certain areas of employment for the ambulatory physicians, and the one that showed, yeah, that one that had the 15%, the next one.
Oh, that.
It was the donut graph.
Back
you
that
had.
way.
There we go. And this is for clinics, right? This is.
Yeah, they asked for
Clinics.
providers.
Okay,
Yeah.
so it's really interesting to see data statistics and analytics for clinics that only there's a 9% interest at this time. And obviously hospital systems and ACOs and health information exchanges, I would venture to guess that it's probably closer to 50 or 60% on that number there. Do you see the workforce need growing in the clinics? Or do you think private practice, in your case, the primary care providers relying on industry or healthcare systems or EMR vendors to fill in that space in the future?
Yeah, and I think there's going to be some challenges to do it for individual practices. So what we found is that those practices that are less than, say, probably 9 docs, if you're talking about 10 or more docs, then they may have enough revenue to pay for some type of full or part-time IT person into the mix. So for those, larger practices, then I could see where them hiring somebody to do this, especially those that are part of provider-led ACOs, actually purchasing those employees and putting them to work. I think the vast majority of them are going to have to be done through some type of consultancy or service. So I would, so this is all conjecture and just my foreshadowing that I can't really see, is that there'll be a setup consultant that'll be able to come in, start to create those best practices, start to create the standardized reports that are needed, create the data standardization that's needed to be able to drive those analytics, and then that'll be converted into more of a service that can then be put into the cloud and delivered in that regard. I just don't think that there's ability from a financial business model to support each of those small practices having their own data analytics person. It's going to have to be larger than that, either some service from the EMR company or some third party if we're able to get the data out of these systems.
Thank you. Other questions? Oh, we have one in the back.
You have to tell me how semantic search works before you can ask your question.
So along those same lines, do you think the thought there with the 9%, is that reflective, in your opinion, of a misunderstanding of what statistics and analytics might do for us in the future? Do you think any of that has to do with just maybe not really getting the need?
Yeah, I think it's some of that. I think it's the fact that they don't have access to the data, that somebody else is providing that if they're thinking about that today. I still think that it's the whole value-based payment stuff is still a future. And as you start to get to smaller practices, their time horizon is maybe 18 months. So I think there's also this notion of, oh, that's something we have to deal with in a couple years. I don't have to deal with it now type of issue. And then also I think it is the fact that they don't quite understand what is data analytics and what do I actually need. So they just don't know that that's going to be a need for them moving forward. I think they understand that there's this ACO thing, but I think a lot of the smaller practices think like, oh, well, the health plan or somebody else is going to do all the analytics. All I need to do is, quote unquote, take care of the patients. So I think it's all that. And I don't know what percentage each one of those contributes to this particular low number.
Okay, any more questions? Okay, well, thank you, Dr. Waldren, for all your insight on the national health IT workforce. We're very fortunate to have Dr. Waldren here in Kansas City to represent us and work with us for the national workforce, and just his information that he shares with us all the time. So thank you. Thanks. We have a